Okay, my name's Julia Camps. I work in the east of Spain, in the Hospital Universitario de la Ribera, near Valencia. And I'm going to talk about imaging after treatment of benign breast conditions. This is kind of also a tough talk, even tougher maybe than the previous one. And we talked it, Dr. Fuchsjäger and I, and I'm going to talk about the same things, but giving it a slightly different angle. So we both hope that you will learn from the session. Now, the first question is, we have a 53-year-old patient with a painful nodule in the left breast, and we know that she's had trauma in the upper inner quadrant of the left breast. This is the first ultrasound. This is 6 months later, and this is the concurrent mammography. Now, the question would be, which would be the most likely diagnosis? Fat necrosis, fibroadenoma, invasive ductal cancer, or hemangioma? Please vote now. Okay, good. Most of you got it correct. Fat necrosis. We are starting where Dr. Fuchsjäger left. He said, be aware of fat necrosis. So that's where we start. Okay, in benign breast conditions, as in malignant breast conditions, we have an injury and a result of that injury. The injury could be due to, in our case, percutaneous biopsies most of the time, also surgical biopsies, not so frequent now because we are more and more accurate with our percutaneous biopsies, but we can also have changes due to mammoplasty performed for benign reasons, and of course the auxiliary techniques, which we will talk about later on. As a result of this injury, we can have all these findings: fat necrosis, fluid collations, we've already seen that, and foreign bodies, which will be slightly different from the ones you saw here, and of course also anatomical changes like in the malignant counterpart. Now, we will talk about fat necrosis. The fat necrosis is a complex process, and I really advise you to take a look at this poster. I think you can download it online. I'm not sure about that, but this is a very fine work that Dr. Sergi Ganao from Sabadell, Spain, did. He also got a prize for it, trying to explain the underlying mechanisms of fat necrosis. And I think that if you understand the underlying mechanisms, it will be easier for you to recognize what you're looking at when you're imaging these patients. Now, both, and the Oscar goes to these both protagonists, which are vessels and adipocytes, or fatty tissue. Those are the main two actors in this film. Fatty tissue and vessels. Okay, what happens when we perform an injury on these two tissues? Well, on the phase one, we have an arteriolar constriction, but later on there is a vasodilation and there is a trasuda due to a high pressure edema that builds around the site. This vasoconstriction is trying to avoid that we lose blood when we have a trauma, but there are some mechanisms that, due to the high pressure that builds inside the venules, then we have edema around these vessels. So the first thing you're going to see, the very first thing, is edema, which can be very subtle on mammography, and also it can also be very subtle in ultrasound, as in this case we can see that it's, you can see an ill-defined hyperechogenicity due to edema. This is what it is due to. And in MRI, you can see a high signal intensity, especially in T2 weighted images. This is the first phase of fat necrosis. Now, what happens in the phase number 2? This is the most complex phase, and it's important for you to understand what's happening here, because you're going to have some problems if you don't really understand what's going on. Now, what happens here is that we have fibrinogen inside the vessels. These vessels rupture, and this fibrinogen, due to the clotting cascade, is transformed into fibrin. Okay, now this fibrin forms a mesh with fibroblasts and angioblasts, and as well as leukocytes and macrophages, and this is the origin of granulation tissue. Now, I want you to take note that angioblasts are part of this. So, and I will explain you why it is important that you know that angioblasts take part in this second phase. This granulation tissue will evolve in time, as you saw in the very nice schema that Dr. Fuchsjäger showed you before. It will give rise to a scar of fibrosis, and we will see later on also calcification or of calcified scar. What we can see when we see a scar formation, this is a patient who had surgical biopsy for benign lesions here in the left breast. In the in the left breast, in the craniocold view, you can't really see much, can you? Because this is a dense breast. She complained of a palpable lump in the left breast. Now, in the ultrasound, we can see an ill-defined lesion with not very well defined. And when we did an ultrasound, we were concerned because although the woman swore that she had had a biopsy, a surgical biopsy for benign lesions, she had this palpable lump. And therefore, we didn't like the images, we didn't like this, so we were concerned that this might be cancer. So we did an MRI, and in the MRI, as you can see, this is the ADC map, this is the EP-T2 diffusion image, and this is the contrast subtraction image. As you can see, this scar can give you false positive image in diffusion. It can even give you a very low ADC value, but the good news is that it wasn't enhancing, and as we saw in the previous case, in the previous lecture, when it is not enhancing, you can call it a scar confidently. So this is what we could see in the T1 weighted image, no enhancement and signal void due to the scar formation. So this is what you're going to see with a plain run-of-the-mill scar. Okay, but, and I told you before, the angioblasts also have a role in this matter, in this fat necrosis, in this second phase, and that is why you are going to have enhancement around in the fat necrosis side. And this, well, not in this case because we're talking about benign conditions, but if you're talking about a patient with a previous breast cancer, you have to take into account that this can be due to a benign finding. It's an inflammatory phase of fat necrosis, and you can differentiate it very nicely in this case from a recurrence or a cancer by the fact, due to the fact that there is fat in the center of the lesion. So this is a very important sign that will let you differentiate between recurrent cancer or first-time cancer, and fat necrosis. As in this case, we did not do anything to this patient. We followed her up, and 12 months later, it was slightly less. So this is what happens. This is the most important phase for radiologists, which is going to give you the biggest promise. We have the third phase in which the fatty acids are released from the adipocytes, and then they precipitate with the calcium ions in the tissue, and this is the origin of the famous eggshell calcification that you will see very nicely in mammograms. Before these eggshell calcifications, we have a phase where you can still see the little rim capsule around the oil cyst and the translucency due to the fact. This is what we would see. This is a tomo image where you can see it very nicely, an oil cyst with the contents of these fatty acids released by fat. Now you know why you're seeing this. This is another image, very nicely shows, and in this image you can also very nicely see the evolution of an oil cyst, what happens when it calcifies, because you now know that it is due to the fact that the fibrin in the tissue precipitates, and also the fatty acids precipitate with the calcium salts, and they form the famous typical eggshell calcification of oil cyst. If you see them with ultrasound, in the first phases when they are organizing, you might see this and you might have some diagnostic problems. But in the late phases, you just see this very nice hypoechoic lesion, well-defined. This is an oil cyst, especially if you see it in the midst of an area where there's been a surgical injury. This is what you would see in MRI, the same thing. Sometimes, this is fat necrosis, this capsule can enhance, but it's a very well-defined enhancement, no problem with that. The fourth phase can go simultaneously apart from the second phase. So it can happen that you don't get oil cyst. It can happen that the fatty acids do not interact with the calcium salts, and what happens is there is a foreign body reaction. And this foreign body reaction, the body reacts with granulation tissue that later on will calcify. As you saw from the schema that Dr. Fuchsjäger showed you before, this can take even years. This is not a very immediate process. So these are the images that you would get after any surgical injury to the breast. You can see the surgical scars, and then you can also see all these dystrophic calcifications around the surgical bed. In this case, they are following a line, and this is the image that you would see in ultrasound. If you were concerned with this image, if you took a mammography, you would very easily see that this is an eggshell calcification. No problem with that. This is the same case, the eggshell calcification forming around the oil cyst, and this is the corresponding ultrasound image. Of course, as we saw in the previous lecture, the sutures can also elicit foreign body reactions, and what happens is that the calcium salts around the tissue will precipitate following the morphology of these sutures, which we will very nicely recognize and differentiate them from suspicious microcalcifications. In MRI, we can see signal voids corresponding to these oil cysts that have evolution to calcification. But it's also funny that if you do a lot of MR imaging, in this case it was due to breast conserving surgery, but if you do a lot of imaging, you will see that you would also see many signal voids which do not have the corresponding calcification in the mammogram. And we always talk about this. We think that maybe they are the result of surgery or cauterization when the surgeon is trying to avoid hemorrhage. Maybe this is an evolution. This is one of the causes. At any rate, you will see this, and many of the times you will not see the corresponding image in mammography. Now, as an apart, I would like also to tell you that due to the fact that we are having more and more advanced biopsy systems and more advanced biopsy procedures, we also have to recognize what happens, as in this case, after a complete excision of a fibroadenoma with vacuum-assisted biopsy. This is a complete excision. As we can see, there is nothing left in the tissue. This case was nicely lent to me by Dr. Torres Tabanera from Madrid, as like the second case. In mammography, we can also see sometimes you have this fibroadenoma treated with vacuum-assisted biopsy. You might get some scars that we're going to be kind of difficult to diagnose alone if you don't know the past history of the patient. At any rate, you have to know that you might get some scars after these biopsy procedures, as also in this case, this is another cause of another type of advanced biopsy system utilization. It is papilloma excision with vacuum-assisted biopsy, done more and more frequently in order to avoid surgery. In this case, we have a papilloma 2 months after excision with vacuum-assisted biopsy. Note the difference between the previous papilloma excision done by surgery and the little, very small scar that was left after vacuum-assisted biopsy. I think maybe this is the way to go. Okay, we get to question number 2. This is a 36-year-old patient with a previous core needle biopsy. This is the T2, T1 weighted image and subtraction image, coronal and axial. Okay, the most likely diagnosis in this case would be a post-biopsy seroma, a post-biopsy hematoma, complex fibroadenoma, or a BIRATS 5 lesion. Please vote. Okay, you got it right. Most of you, almost 60%, you got it right. It was a hematoma. Actually, a seroma is something that you get after a surgical procedure. Okay, hematoma is more the most frequent finding after if we have a complicated biopsy. So, in this way, we go on to the second part of our talk, fluid collections. You already seen mainly fluid collections would be hematomas, seromas, or abscesses. Just take into account that hematoma can enhance in the periphery, and the signal intensity in T1 and T2 images will vary over time depending on the state of the hemoglobin. In this case, this is high protein fluid. It varies all the time, over time. It can give us problems right after we do the biopsy, as in this case. This last case was an old hematoma. This was a new hematoma. It can give you more problems because you don't really know, especially if you're staging a patient, you don't really know what enhancement can be due to extensive intraductal component and what enhancement can be due to a hematoma. So beware of this thing. In this case, we had this nodule which we biopsied, and this is the finding that we got after hematoma. Not all hematomas are round fluid collections. Some hematomas can be interspersed in the breast tissue, and maybe sometimes they enhance and they can give you some diagnostic problems. So beware that it is not frequent that we have a hematoma after ultrasound-guided biopsy, but sometimes they can give you diagnostic problems. In this case, we have a very recent hematoma, and they can give you false positive images in diffusion. Remember this, diffusion sequences are sequences that we use more and more frequently. We use them now all the time. The good thing here is that there is nothing enhancing here. And there is also nothing in the ADC map, but remember, it can give you a false positive image. Seroma, we've already seen this. They have a very fine capsule. More frequently, this is the post-axillary surgery. And over time, you might get fibrosis as they shrink over time. Abscesses can give you a low-level echo in a collection, but beware that in ultrasound sometimes they can behave like a tumor with ring enhancement. And the good thing, sometimes it's not difficult clinically to differentiate them from highly necrotic tumors, but of course, sometimes you have to end up biopsying them. It's not what happens all the time. This is another case, also a false positive image in diffusion ultrasound and progressively enhancing ring lesion. Okay, question number 3. 39-year-old patient, routine follow-up for breast implants. This is the T2 coronal image further back and in the anterior breast, and this is the corresponding silicone-only sequence, okay? What is the most likely diagnosis here? Normal, intra and extracapsular rupture, right contracture, bilateral rupture. Please vote. Okay, good. Good for you. Most of you got it right. Okay. We're talking about an intra and extracapsular rupture because you see the silicone in the lymph nodes. Very good. Okay. This is the third part of our talk. We'll talk about the different foreign bodies. I consider breast implant foreign bodies in the breast. Also, we'll talk about lipofilling and macrolane as auxiliary techniques. And last, we talk about clips. Breast implants, they're mostly silicone breast implants, but of course, you can also have saline-filled implants. This is due to the scare of the silicone scare in the 1990s. But most of the time, you will be seeing this. This is the higher signal intensity of saline, and this is a lower compared to this signal intensity of silicone. The location of breast implants can be either retropectoral or subglandular. So this is the location of the implants you have to report when you talk about the implants. The most frequent sequences we use would be T2 and silicone only. Silicone only image is a must. You cannot substitute silicone only with stir images because in stir images you do not suppress water. So you want to suppress water, and you want to suppress fat. You only want to leave the silicone only signal in order to diagnose extracapsular ruptures rightly. And also it is very important that whenever you do T2, you have to do perpendicular planes. You have to use axial and coronal or axial and sagittal. Whatever you do, always do in 2 different planes. It is very important. Most frequent complication is capsular contracture, but this is something you don't have to worry about because it's a clinical diagnosis. You have to worry about how to diagnose intra or extracapsular contracture and rupture, and of course infection. Rupture increases with time, although most often it is silent, and although you can diagnose it very easily with ultrasound, MRI is the most sensitive and the most specific technique. We start with intracapsular rupture. There are certain signs and there are possible signs. Be careful about this because you will have to see them in many consecutive images in order to call this a rupture. So the best signs, if you see them, the best ones are the linguini and the subcapsular line sign, but the other signs, you will have to see them in more than one image to call them a rupture. They are the teardrop or the keyhole or the noose sign, and also the salad oil sign. Beware, because the radial folds are a normal finding and they do not constitute a rupture. The intracapsular rupture in ultrasound you can see as the silicone, the snowstorm, the typical snowstorm of the the ruptured silicone. You can see it in one part of the breast, but contained by the capsule. Okay, but the most the best technique to diagnose truly the rupture would be MRI. This would be the linguini sign. This would be the subcapsular line sign. Be careful, it has to measure more than 3 centimeters to call it a sign. And this would be the keyhole, noose, or teardrop signs. And be careful, because you have to see them in more than one image and preferably in 2 different planes. That is why you have to do perpendicular planes in T2. The salad oil sign appears when the bodily fluids come in contact with the silicone, and that only happens when there is an intracapsular rupture. But be careful, because if the patient has had previous steroid injections to treat capsular contracture, you might get false positive findings. So you have to elicit the most information that you can from your plastic surgeon in order to do a correct diagnosis. The radial folds, we say, they do not constitute a rupture, they are a normal finding. Okay, now with the extracapsular rupture, the certain signs of rupture is the finding, the certain sign is a finding of the extracapsular silicone goblets. Okay, now why is silicone in lymph nodes not so certain or trustworthy? Of course, if you see it, it is a sign of a rupture. How could have the silicone entered into the lymph nodes? But remember that you have to ask the patient, and this is frequent nowadays. Patients get operated on many times due to previous rupture. You have to rule out that the patient had a previous rupture and they changed her implants, okay? So this is very important. Again, you have to elicit the most information from your plastic surgeon. This would be what you see, the typical snowstorm of the extracapsular rupture. In this case, they were lymph nodes. This is the isolated silicone. This is what the extruded silicone looks like, and this is what it looks like on T2 and on silicone only. Just take a look at this image. Here you would see, well, this is not normal, this has the same single intensity, but the best way to diagnose this would be a silicone-only image. So take great care with your technician, because this sequence can be very tricky and difficult to get right, but take great care, and also with your applications technologist, and get this sequence right. If you have an irregular margin, it can be a sign of a rupture, but there is a pitfall, because if the capsule is calcified, that's what happens over time in old implants, you can have a normal, non-ruptured implant with a calcified capsule, and that is not an extracapsular rupture, okay? And also there is another pitfall when you can have a capsule herniation. This is not extracapsular, and the extruded silicone must be documented in different orthogonal perpendicular planes, okay? This is important. This is a reconstruction I did from the silicone-only image, because this was the actual image. If you see this image isolated, you could say, well, this is extruded silicone, but if you do reconstruct the image in another plane, you will see that this is capsule herniation. Silicone in lymph nodes, of course, is a sign, but could be a false positive sign if previous ruptured implants or a thing that is called gel bleed, and nobody really knows what this is. It happens when the silicone in the implant is not so cohesive as the new silicone implants we're getting now. So this happens, it will happen, you will see the silicone in the lymph nodes, the patient will be operated upon, and the plastic surgeon will get the implant, and it will look sticky, but there will be exuded silicone, but there will be no sign of rupture. This is a phenomenon that it is not very frequent, but it can happen. Of course, in the silicone-only image, if you see silicone in the lymph nodes, you can call this a rupture, but be careful, because for some reason, sometimes you get very hypertrophic. This is not normal, but for some reason, due to the fact that you have a foreign body reaction maybe in your body, you have very hypertrophic internal mammary lymph nodes, and then, as in this patient, you do the silicone-only image, there is no silicone. So this does not constitute a rupture, an extracapsular rupture. You have to document the silicone in the lymph nodes. Of course, in very, very rare cases, you can even have siliconomas in other locations. There's, in this case, in the upper and posterior mediastinum. As we said, capsular contracture is the most frequent complication. There is a clinical classification of the Baker classification, and this is something that you will not really be asked to diagnose. This is a clinical diagnosis. It would be less, they say it's less common in a subpectoral placement. You can only say sometimes that the AP and transverse diameters, this would be a normal implant, and this would be an implant with a contracture. If you see that both diameters are equal, then maybe you can say, maybe this patient has a capsular contracture. But again, this is a clinical diagnosis, and this is what it looks like after they explant the implant. Okay, infection is really rare and may lead to explantation. They will ask, whenever they ask you to rule this out, you have to do a contrast-enhanced MRI. And this is what it looks like. You will have a very always very subtle or very intense rim enhancement around the implant. But of course, you always have pitfalls in imaging. We can't escape that. And you can also have inflammatory enhancement, which does not constitute a real infection. Okay. We go on to the fourth question, 54-year-old patient with a previous autologous breast reconstruction in the right breast. This is what it looks like in T2 and T1 weighted images. She had a deep reconstruction. This is what it looked like in the ultrasound, kind of a collection. Very funny looking collection. The most likely diagnosis here would be simple cyst, multiple abscesses, post-op abscesses, hyaluronic acid injections, or silicone gel migration from left breast. Please vote now. Okay, good, very good. The auxiliary techniques we were talking about. Hyaluronic acid is something that is being, it's banned in Spain actually now. The Senologic Society was asked to give in Spain its opinion, and it's banned now, and we will see why. Okay. The auxiliary techniques are becoming more and more frequently together with the oncoplastic reconstructions, but also due to aesthetic reasons. So this is why you have to know what happens when the plastic surgeons inject these substances into the breasts. There are two main types: lipofilling, this is autologous fat transplantation, and hyaluronic acid or macrolane. The lipofilling, the surgeon gets there's a centrifugation of the patient's own fat. This is done through what is called the Coleman technique, and what the surgeon does is that it creates a 3D lattice in very, very small goblets, because otherwise there would be a huge fat necrosis if you injected it all at once. So that's why they do it in very, very small goblets. This is how they do it in real life. And the problem of this technique, it's being used more and more frequently, but the problem is that it can give you a lot of headaches as a radiologist, because apart from the fact that it is under investigation, because there's a certain concern that there's a stimulation of neoangiogenesis through adipokines, which are contained in the patient's fat. There is also, they say it's not so successful because you can have 30 to 70% of fat reabsorption. And of course, for the radiologist, the problem is that you will get microcalcifications, as we saw in the previous slides on fat necrosis, due all the secondary findings due to fat necrosis. And some authors recommend follow-up with MRI. This is the systematic review by some authors in Brazil. This was published very recently, and they say that there is broad clinical applicability and complications were few. There was no evidence of interference with follow-up after treatment for breast cancer, but oncological safety remains unclear. This is one of the few patients I got. This patient was status post mastectomy for breast cancer. So as you can imagine, when I saw this, I thought, oh gosh, I mean, this is a multicentric relapse. But if you look closely here, you will recognize the typical image of fat necrosis. Fat surrounded by a hypointense capsule of fibrosis. So this is what you have to look for. Unfortunately, it can be quite a challenge to diagnose. This is also a breast cancer patient, and although you can see the fat inside all the area that's enhancing, sometimes it can be quite a challenge to differentiate this, especially in the oncologic setting, this from a relapse. Now, macrolane is different. It's also under investigation, but more under investigation. It was approved in Europe, but not by the FDA. And the biggest problem is that it interferes with imaging, and most of the patients will have to end up having MRI exams to detect cancers, rising costs. So this is what happens after macrolane. There's no way you can diagnose an underlying cancer in this patient. And this is the high signal intensity, which you saw in the question, the previous question. That is what you will find with MRI. Now, if you have any concerns about the famous PIP implants, let me just tell you that the NHS issued these recommendations, and they say that there is no evidence of significant risk to human health. The problem with PIP implants is they are significantly more likely to rupture, and the rupture is really very complicated rupture with lots of inflammatory signs. The surgeons will tell you that it's going to take them, it takes them longer to explant this breast implant. So this is the problem with the PIP implants. And regarding breast implants and cancer, there's this recent meta-analysis from Canada, and they concluded that the research would this conclusion was not what we heard in the previous year. So it was actually a surprise for me to find this, because they said that the research published today suggests that cosmetic breast augmentation adversely affects the survival of women who are subsequently diagnosed as having breast cancer. But these findings, of course, they always end up saying the same thing. They should be interpreted with caution because some of the studies included in the meta-analysis did not adjust for potential confounders. But take this message home. Maybe we'll have to wait and see what happens in the future. Now, the last type of foreign bodies we talk about are clips. Clips, we use them more and more often. We do all sorts of biopsies, MR-guided biopsies, whatever biopsies. You have to, sometimes it might be difficult to recognize, sometimes a little bit more easy, as in this patient with a complex cystic and solid lesion. You can see them inside the lesion. And there is this new generation of hydrogel-coated clips, which will be much better. This is what the mammogram with the hydrogel coating, and this is how it nicely shows in MRI. But you have to know they are there. The most frequent run-of-the-mill surgical clips, you can see them very nicely on mammogram, and on the T2 and T1 weighted images, you will have the ferromagnetic artifact, the characteristic ferromagnetic artifact, and now you will be able to call them clips. Sometimes they will give you a headache because they will have such a big ferromagnetic artifact that they're not going to let you see the rest of the tissue, but let me tell you that this is not very frequent. Okay, last question. 42-year-old patient. This is a routine follow-up. This is the OML of both breasts. This is a chronocaudal view. This is the ultrasound, this is the MRI image. Okay, notice this. What is the most likely diagnosis here? Bilateral non-calcifying DCIS, status post bilateral chronic mastitis, status post reduction mammoplasty, scarring post multiple biopsies. Okay, vote now. This is the last question. Okay, very good. You got them all right. Okay. This is the last part of the talk, what anatomical changes we will have due to surgery for benign breast conditions. Most, they can be divided into due to augmentation mammoplasty, which we just saw, and also due to reduction mammoplasty, which can be due to benign region. The patient has big breasts and has problems with her back and wants to have a reduction mammoplasty. This is not an uncommon clinical setting. And also in those patients with a breast cancer and reconstruction surgery in one breast and then symmetrization of the other breast so that it looks aesthetically right. In reduction mammoplasty, you have a V-shaped sliver of fibroglandular tissue that is taken out, and that is why you will have these linear images in the breast. When you see more than 2 or 3 cases, you will get used to them and you will be able to, without having any information, this patient has had a reduction mammoplasty. This is what happens, the same thing, the V-shaped in MRI. Remember that there can be some certain scar enhancement in this case, because this is fat necrosis in inflammatory phase, remember. And you can also have very prominent fat necrosis findings in these patients, of course. Sometimes you're going to have problems to diagnose what's underlying these big scar after reduction mammoplasty, as in this patient with a previous breast cancer and a symmetrization mammoplasty of the right breast. As you can see in the MR images, this was the reconstructed breast, and this is the symmetrization mammoplasty. You can see a very small recurrence in the normal or healthy breast, which you can unfortunately not glimpse on the mammography. this would be another image of a semi-traumatization mammoplasty. So to finish the session, what we learned is that after an injury due to benign or malignant, you have all these findings that you, I hope, will be able to recognize and also to differentiate and also to know what are the underlying mechanisms of fat necrosis and how these mechanisms translate into the images that you will see. The fluid collections are also common to any patient operated for breast cancer. We have different silicone, autologous fat and clips, also foreign bodies that we will have to try to identify, and of course the anatomical plane changes due to mammoplasty. Thank you very much for your attention.